Hello and welcome. We will continue where we left in part 1. So, let's start. Please take a look at the learning objectives. Antiarrhythmic drugs are classified according to the ion channels or receptors they block. Class 1 sodium channel blockers. Subdivided into 1A. Quinidine, procainamide, disopyramide 1B. Lidocaine, mexiletine, phenytoin 1C. Flecainide, encainide, propafenone, morrison. These differ in how they bind to sodium channels, whether in the resting, activated, or inactivated states, as discussed in more detail in the next slide. Class 2 beta-adrenoceptor blockers. Examples: propranolol, atenolol, metoprolol, esmolol. They reduce sympathetic drive, slowing SAW and AV nodal conduction. Class 3 potassium channel blockers. Examples: amiodarone, ibutylide, dofetilide, sotalol. Sotalol, although a beta blocker, is classified here due to its dominant potassium blocking effect. Class 4 calcium channel blockers. Examples: verapamil, diltiazem. Unlike dihydropyridines, such as nifedipine, which act on vascular smooth muscle, these target cardiac calcium channels and slow nodal conduction. Class 5 miscellaneous agents. Examples: adenosine, digoxin, magnesium sulfate, ivabradine, ranolazine. Each has a unique mechanism outside the traditional channel blockade. Please note that the drug names shown in bold font are the ones commonly used. Class 1 drugs primarily act on ventricular myocardium, with little effect on the SA or AV node. Class 2 and 4 drugs act maximally on the SA and AV nodes, as these depend on sympathetic tone and calcium currents. Class 3 drugs mainly prolong the duration of the action potential and refractory period, reducing re-entry arrhythmias. In practice, supraventricular arrhythmias arise above the ventricles, e.g., SA or AV nodal circuits. Ventricular arrhythmias originate within the ventricles. Different drug classes target these distinct sites depending on their electrophysiological effects. A plus sign denotes utility, such as 3+ means strong utility. Let's begin with Class 1 antiarrhythmic drugs, the sodium channel blockers. They act primarily on phase 0 of the action potential, but their adverse effects often reflect both cardiac and systemic involvement. Procainamide can prolong the QT interval, predisposing to torsades de pointes and syncope. It also has ganglion blocking properties, leading to vasodilation and hypotension, and with prolonged use may cause an SLE-like syndrome. Other side effects include gastrointestinal upset, fever, rash, hepatitis, and agranulocytosis. Quinidine shares the risk of QT prolongation but also causes synchronism, a classic triad of headache, dizziness, and tinnitus. Additional problems include GI irritation, thrombocytopenia, and angioedema. Disopyramide similarly prolongs QT and can cause a V-block or congestive cardiac failure, along with anticholinergic effects like dry mouth, blurred vision, and urinary retention. Notice that all three agents can precipitate arrhythmias by prolonging repolarization, hence the need for close ECG monitoring during therapy. Next, let's look at the remaining Class 1 subgroups, 1B and 1C. Lidocaine and mexiletine, both Class 1B agents, are considered the least cardiotoxic among sodium channel blockers. Their adverse effects are mostly neurological, paresthesias, dizziness, slurred speech, and sometimes convulsions. Bradycardia may occur, but serious rhythm disturbances are rare when used correctly. Flecainide, a Class 1C agent, suppresses premature ventricular beats but can paradoxically exacerbate arrhythmias, especially in patients with prior myocardial infarction. Hence, its contraindicated post-MI propafenone has a similar cardiac profile but also produces metallic taste and constipation as distinctive side effects. These drugs must be prescribed with caution. Class 1C agents in particular are potent but potentially dangerous. Moving to Class 3 potassium channel blockers, which prolong repolarization and the refractory period. Amiodarone is the most widely used agent here due to its multi-channel activity. It causes AV nodal delay and bradycardia, but its main concern is tissue accumulation. It deposits in the lungs, liver, cornea, skin, and thyroid. This leads to pulmonary fibrosis, hepatitis, corneal microdeposits, photosensitivity, and optic neuritis. Because it contains iodine, it can induce either hypothyroidism or hyperthyroidism. Ibutylide and dofetilide both prolong the QT interval and can trigger torsades de pointes, a potentially fatal ventricular arrhythmia. So while Class 3 agents are effective for rhythm control, their monitoring requirements are quite strict due to these potentially serious complications. Let's now discuss the rate-controlling classes, Class 2, beta blockers, and Class 4, calcium channel blockers. Class 2 beta blockers such as propranolol and metoprolol can cause bradycardia and hypotension, bronchospasm in asthmatic patients, and in diabetics, masking of hypoglycemia symptoms like tachycardia and tremors. Class 4 calcium channel blockers such as verapamil and diltiazem produce vasodilation and hypotension, AV block due to excessive nodal depression, constipation, and sometimes a general feeling of fatigue or lassitude. Both groups reduce conduction through the AV node but must be used judiciously to avoid excessive cardiac suppression. Finally, the Class 5 are miscellaneous agents. These don't fit neatly into the previous categories but are clinically important. Adenosine, often used for acute termination of supraventricular tachycardia, may cause flushing, bronchospasm, hypotension, and nausea. Fortunately, its very short half-life means these effects are brief. Digoxin toxicity produces nausea, vomiting, and a range of cardiac arrhythmias, particularly with electrolyte imbalances like hypokalemia. Magnesium sulfate, used in torsades and certain eclampsia-related arrhythmias, can lead to fatigue and muscle weakness, especially with overdose. Next we discuss two drugs which may prolong QT interval but do not predispose to torsades de pointes. One of them is ivabradine that works by selectively inhibiting the funny current in the sinus node, which slows heart rate without affecting blood pressure or contractility. As we know, this funny current is responsible for phase 4 slow depolarization. It is used to treat chronic stable angina and certain types of heart failure, but its antiarrhythmic properties are primarily linked to heart rate reduction. Hypokalemia, hypomagnesemia, and bradycardia are contraindications to ivabradine use, as all of these conditions would increase the likelihood of prolonged QT interval. The other drug is ranolazine. While originally approved as an antianginal medication, it is also effective for rhythm control. It acts by inhibiting late sodium current in ventricles and atria. It also inhibits peak sodium and potassium currents in the atria. This mechanism helps suppress both atrial and ventricular arrhythmias, including atrial fibrillation and ventricular tachycardia. Nausea, dizziness, and fatigue are its side effects. In summary, while each class has therapeutic value, the risk-benefit ratio must always guide selection and dosing. Take your time to closely interpret this table. This bar chart shows an estimated frequency of use as overall prescription share. The data is from freely available data. Amiodarone is the most common drug used. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!